Good morning. I am Dr. Lasso from France. I am a radiologist in the most important European oncology center. My goal is develop a new technology, the dynamic contrast enhanced ultrasonography, in order to evaluate earlier patients treated with new anti-angiogenic drugs. So in my work, I am both clinical in unit, and I am also a researcher, and I try to develop and to reinforce the new methodology. So I would like to explain the interest of dynamic contrast enhanced ultrasonography for the early evaluation of anti-angiogenic treatments. So before, I would like to give you an introduction of angiogenesis. Remember, we have a lot of angiogenic factors, more than 30, and the strategy is to block the development of neovascularization in order to stop the tumors. So concerning the major mediator of angiogenesis, the vascular endothelium growth factor, you could stop him by different ways. Using upstream activators or antibody as avastin or with the downstream pathway. Remember, in oncology, we have currently 200 approval drugs, but also more than 800 new drugs in R&D. And all molecular targeted therapies are expected to experience a positive compound annual growth rate between 2006 and 2016. The major point is, if you check this slide, all drugs target the same receptor. You can see here the VEGF receptor. And we don't know, and we don't have currently a biomarker in order to select the best drug for the patient. And the major example is the renal cell carcinoma. Remember, we have 5 new drugs, approval in 3 years, and we don't know which is the best drug for the patient, if this is the bevacizumab, the sorafenib, the sunitinib, and the mTOR inhibitor. And probably the functional imaging could be a biomarker in order to select the best drug. So finally, what do we need tumor functional evaluation? Because the new treatments in oncology targeting angiogenesis induce the destruction of neovascularization and necrosis, often without tumor volumic changes. And if you check these patients, so before 12 months and after 9 months, according to the RECIST criteria, we don't have the modification of the size, but you immediately understand that probably we have a necrosis. And the goal of the functional imaging is to try to quantify this necrosis and to correlate this necrosis to the follow-up of the patient, to the progression-free survival, and to the overall survival. So finally, 2 goals: to save time for patients, and also to save money for economical models. And the challenge of DCE-US are to select which is the most appropriate drug. And we would like to give this answer earlier before the RECIST criteria. So in my institution, when I start in 2000, it was only with a qualitative analysis. At the beginning, only with a Doppler, and we made the first phase 1 of sunitinib, published in JCO. And after, we used the contrast agent in 2001, the Levovist and Sonovio, the approval contrast agent in Europe. And we decided to start in different tumors. So for example, in sarcoma, treated with tumor necrosis factor, or in GIST with Glivec, or in kidney cancer with the new drug, the sorafenib. And the goal was to convert the oncology only with a qualitative analysis, that probably we have a very sensitive tool in order to select immediately the best drug. And on this slide, we have a patient on CT scan before 12 months. It was a pelvic tumors, and after 1 month, you don't have the modification of the size, but if you check the DCE-US, you immediately understand that after 1 month, you have a beginning of the necrosis of tumor. And we also demonstrate that in metastatic renal cell carcinoma. On the left, it was a bad responder, so before 12 months, and after 3 weeks, we don't have the modification of the vascularization. And if you compare with a good responder on the right, this is a vascularized lesion, you immediately check after 3 weeks the beginning of the necrosis, more than 80%. And when the oncologist received on the computer this kind of image, he wanted finally to use this kind of methodology. But we had to solve some problems with functional imaging, and currently we don't have a consensus about the parameter, about the timing for the evaluation of these new drugs. And this is the same problem with the CT perfusion, DCE-MRI, and DCE-US. And the key point is the standardization. In fact, you had to understand, if you have a tumor, you could evaluate this tumor by using different way. You could evaluate, in red, here, the blood flow, which perfuse the tumor. You could also evaluate the blood volume, and often in publication you had these parameters. The blood volume, this is the percentage of the vessels in the total tumor. This has the MVD, the microvascular density at histological analysis, but with the functional criteria. And we could also measure the mean transit time. But remember, the difference between the DCE-US and the CT perfusion and DCE-MRI are the size of microbubbles. In fact, our microbubbles stay in the vessels, so we are not able to evaluate the permeability and the catrons. So the next point, very important, is the methodology. And we published a paper with David Cosgrove from London and Pierre Perronneau, which is an inventor of the pulse Doppler. And 4 years ago, all companies provide us only the quantification on the video screen. So this quantification was performed after the cosmetic logarithmic compression. And finally, it was a first quantification. And the good news are now all companies, Toshiba, GE, Siemens, and Philips provide this kind of data. So you have access to the high dynamic range, about 1000, and you could perform a through quantification. The next point is the acquisition. Remember, with these techniques, you have the best temporal resolution. You are able to record 4 frames per second. So you stay on the same plane, you inject the sonoview, and you are able to record the wash-in and the wash-out, and during 3 minutes. So we developed a methodology for deep lesion, and for example, here this is a metastatic in the pelvic area, a tumor measuring about 6 centimeters. Here, this is a very small metastasis from melanoma. This is a tumor measuring only 1 centimeter. And finally, if the patient had only 1 metastasis, very small, you are able to evaluate the treatments. The next step was to develop a methodology in order to perform this curve fitting very quickly, because it's important to save time for radiologists. If you develop a methodology with the time consuming, the radiologists refuse to use these new technologies. So it was very important to work on the workflow and to perform a very quick acquisition and quantification of these parameters. So concerning the parameters, we are able to calculate 7 parameters. In green, this is the parameters correlate to the blood volume. This is the area under the curve, under the wash-in, the wash-out. So this is the total integration under this curve. And also the peak intensity are correlated to the blood volume. In red, the time to peak and the slope are correlated to the blood flow, which perfuse the tumor. And the last parameters, the mean transit time, this is the peak, the half value of the peak intensity, and you calculate the time of between these 2 points, and this is the mean transit time. So remember, as there is no consensus, we decide to standardize the methodology and to calculate these 7 parameters in our study. So the study evaluating anti-angiogenic drugs as antibody with avastin, or with TKI as sorafenib and sunitinib, and also with antivascular drugs. And we developed a workstation in order to calculate in few seconds 7 parameters, because the goal, remember, is to give very quickly all parameters to the oncologist in order to monitor the patient according to the toxicity and the response. The next points concerning the functional imaging, remember this is a motion, and if you perform the DCE-MRI and CT perfusion, you know the problem of the motion. Finally, our strategy was to learn to patient to have a slow respiration. This is a very huge metastasis in the liver, and if you check the very small vessels in blue and red, you understand that probably you stay on the same plane, and after you are able to perform the tracking on this curve. The last point for the technical aspect is the attenuation. You know that this is an important phenomenon on ultrasound, but we understand with Pierre Perronneau that probably, and now we use these techniques, if you put the focus just in front of the middle of the tumor, you avoid and you decrease this phenomenon. In fact, if you perform a small quantification on the superficial area or on the deep or the total tumor, you understand that you have the same quantification. So finally, you decrease this phenomenon. So now let's move to the scientific results. On this slide, you understand that we had this technology in phase 1. Remember, the phase 1, this is a new study when you start the first use of the drugs in the patients. Remember, currently the international rule is only to use the RECIST criteria. But you understand that the company want to use the functional imaging in order to understand very quickly which is the best drug for the best patient in order to push the drug in different tumors, in very selected tumors, or to stop the development of drug if we have no answer with the functional imaging. And we also developed this methodology in phase 2, phase 3, and also in routine. For example, in hepatocellular carcinoma, in GIST, or in melanoma, and in colon cancer, in breast cancer. So concerning the level of validation, we decide to evaluate 4 different drugs in 4 different tumors in order to understand if we have the same parameters and the same timing. So we decide to evaluate the sorafenib, the sunitinib, the mazatinib, and bevacizumab in 4 different tumors. So phase 1, this is a lot of different patients, but also in renal cell carcinoma, in GIST and hepatocellular carcinoma. And concerning the results, we understand we never had 7 parameters, but 3 to 5 parameters. And for the first time, we are able to demonstrate the correlation with the progression-free survival and overall survival. And remember, for the oncologist, this is the best endpoint in order to validate a new technology. So now I would like to show you some examples of patients in different tumors. So we're starting with the renal cell carcinoma. It was a patient with a superficial lesion. You could check on the CT scan, and this is a B mode. You recognize the lesion. And so finally, this is perfect target without motion. We inject the sonoview, and you are able to visualize a very vascularized lesion with the wash-in and the washout. So we follow the patient after 2 weeks. Remember, according to the RECIST criteria, we have no modification of the size. But check, if we inject the sonoview, we have only a very small vascularized. So it's amazing to demonstrate that only after 2 weeks. And this technique is also very useful currently for the sequential biopsy for the genomic analysis. In fact, if you use the morphologic analysis, I could perform the biopsy in different areas. And remember, if you don't have more than 30% of viable cells, you could delete your biopsy. But finally, if you use the SonoView, you immediately target this area in order to have a very high quality of the tissue. And in fact, this patient had a very nice answer because he had partial response after 3 months and 6 months. And remember, only 15 to 20% had partial response. If you check on this graph the quantification, you could see, so before 12 months, in blue the quantification, the time intensity curve, and after you perform the quantification after 2 weeks, cycle 4, cycle 6, and cycle 8. Another example, a patient with a very small metastasis in the neck, you could check on the CT scan. You use the superficial probe, so this is a lymph node, the tumor, and you inject. This is a very vascularized lesion. And in fact, after 2 weeks, we have a strong dramatic decrease of this vascularization only with this very small vascularized area. And after we follow the patient, after 3 months, you could check the lesion on the neck, on the CT scan. On the B mode, it's impossible to understand if you have a necrotic area or not. You inject, and in fact, you have only a very small vascularized area. And we continue to follow the patient after 6 months on B mode and after injection, and this is a quantification. So now we are explain the GIST tumor. So in this very interesting study, we compare our results to the PET CT. And this is a patient with pelvic tumor. So before 12 months, after 1 week, we have the beginning of the necrosis. And after 2 weeks, you can see a dramatic decrease of the vascularization and of the size. And after 1 month, and this is a CT scan. And a very important point for this patient, when we perform the PET CT was normalized. And why? Because remember, the resolution of the PET CT is about 3 millimeters. And this technique is not able to detect these vascularized walls in the tumor, probably measuring 3 millimeters. So finally, the ultrasound is more sensitive than the PET, and this is a quantification curve. So we are moving to the hepatocellular carcinoma. It was a study with patients treated with avastin. So we follow the lesion in the segment 4. This is this lesion in B mode at baseline, and after 1 week and after 4 months. And this is a CT scan after 2 months and after 4 months, and the time intensity curve. So the real tumors. I would like to show you a good responder and a bad responder, and you could check it now. It's very easy to understand if the patient is responder or non-responder. It was a patient with a very rare tumor, the hepatic metastasis from the hemangiopericystoma. So this is the lesion before 12 months, and after 1 week, and after 3 weeks. So a very strong necrosis. And we confirm this necrotic area after cycle 18. And it's very rare to have a long follow-up. Remember, the PFS for the phase 1 patient is only 3 months. But we are able finally after 3 weeks to demonstrate that probably this drug is very useful for this patient. And compare a bad responder, immediately you understand, before 12 months and after 1 week, we have no modification. And we know that probably this patient will be in progressive disease after 2 months. So concerning the comparison, so we compare the 4 study, including more than 100 patients and more than 800 examinations. And we understand that only 2 parameters, remember, area under the curve, the total curve, and area under the washout. This is the parameters correlate to the blood volume. This is the percentage of the vessels of the tumor. And these 2 parameters are always correlated to the response. So probably it was the most robust parameters. And for these parameters, we demonstrate when we perform the DCE-US 3 days after the beginning of the treatments, we have a correlation with the overall survival for the eye under the curve and for the area under the washout. But you had to understand, if you want to validate techniques, if you want to improve the evidence-based medicine, you had to validate your new methodology in multicentric study. So we have a huge support of the Ministry of Health in France and from Toshiba and Bracco in order to diffuse this technique using the raw linear data in 20 hospitals in order to determine, remember, which is the best parameter, which is the best timing, and also to assess the economic impact, because currently we have no reimbursement in France for this technique. So we decide to include 20 centers, and probably you recognize some cities as Lyon, Marseille, and of course Bordeaux. We include 11 comprehensive cancer centers and 9 teaching hospitals, and we decide to teach 65 radiologists, from student to the professor, so very different population of radiologists. We decide to include all patients treated with these new anti-angiogenic drugs. So for example, this is patient with metastasis from breast cancer treated with avastin and chemotherapy. This is melanoma treated with sorafenib, colon cancer treated with avastin and chemotherapy, cyst treated with sunitinib and Glivec, renal cell carcinoma with the 5 approval drugs that we explained at the beginning of this talk, and the HCC with their Nexavar. And we standardize the methodology. All patients had a baseline, an examination after 1 week, 2 weeks, 1 month, 2 months. And we perform a CT scan at baseline and every 2 months. We standardize. Remember, the functional imaging, the key point is the standardization. So we fixed the setting, and when the radiologist starts the acquisition, he pushed on the button and he had to wait 3 minutes. He had to select only one target. We inject the total vial and we record 3 minutes of the raw data. And all examination went sent using a network by internet in my institution in the huge database in order to perform in blind by the engineer the quantification. So we finished the inclusion in last March 2010, so more than 500 patients. And we present in the ERSNA 2009 in Chicago the preliminary results, including the economic results, it's very important currently, the teaching results, how we are able to teach 65 radiologists, and also the scientific results. Concerning the population, so we follow all patients during 1 year, and it's not surprising that we have a lot of renal cell carcinoma, more than 150 patients, because all oncologists understand that we had to use functional imaging. We also have more than 100 hepatocell carcinoma, and finally homogeneous population, more than 50 colon cancer, breast cancer, melanoma, and cyst. And remember, the star of treatments are sorafenib, bevacizumab, sunitinib, and imatinib. Concerning the localization of target lesions, we have half in the liver, and this is an approval topic for the some of you, but we also decide to include patients with superficial lesions and in lymph node, for example, peritoneal area and pelvic tumor. So the results, we perform about 2,000 DCE-US and more than 1,000 CT scans with a blind review. And finally, we lose only 9% of the quantification because, for example, the radiologists lose to push their examination, or we have some technical problems. Concerning the response, and for the first time, but remember, this is only preliminary results, we are able to determine a cutoff comparing the responder and the non-responder. And we have the same parameter. Remember, eye under the curve, eye under the washout. And if you perform an examination after 1 month, if you have a dramatic decrease of these parameters, more than 70%, you are able to predict the response of the patient after 10 months. So some example, the renal cell carcinoma. This is a patient with a huge pelvic tumor on CT scan, and when you inject the contrast agent, so the patient had the treatment during 10 months, and you could check after 1 week, after 2 weeks, and after 1 month on B mode, after injection, and on the CT scan. Another example, very interesting, this is a new combination of the mTOR inhibitor and avastin. So this is a lesion in the segment 6. In B mode, we inject the contrast agent. This is a very vascularized lesion. And after 1 week, we have the beginning of the necrosis. Remember, if you had to perform the biopsy, probably you go directly in this area in order to have the high quality. And if you check the B mode, it was impossible to understand the area with vascularization or necrotic area. And it was the correlation before treatment and after 2 months on the CT scan and the time intensity curve. So a very interesting patient, story of the patient. Remember, now, and we are very happy for the patient, we are able to include the patient in first line, second line, third line. And in renal cell carcinoma, for the patient, it was an amazing story. He had 6 lines. And remember, if you had to follow this patient on CT scan, the dose of radiation will be so much, because if you perform every 2 months a CT scan from June 2004, the dose of the radiation probably could be a problem. So finally, the DCE-US will be very important to follow this kind of patient. So the story of this patient, he had metastatic renal cell carcinoma. So we start at the beginning with the interleukin-2. He had a relapse. We moved to the interferon. He had a relapse. We moved to the Sutent, after the Nexava, after the Toricel. And finally, we start with a new drug from Novartis. This is a multi-tyrosine kinase inhibitor. And we start in February 2009. The patient had metastasis in the liver, in B mode, very vascularized lesion. And after 1 week, we are able to demonstrate the necrotic area in more than 50% in the lesion. And this patient had a treatment during 14 months. It was amazing, because normally the PFS in the first line is only 10 months. And after the 6th line, we are able to demonstrate that probably this is a very, very efficient new drugs. So now we are moving to the colon cancer. The patient with metastatic in the liver, in B mode, before treatments, after 1 week, after 2 weeks, you can see a strong necrotic area confirmed after 1 month. And in fact, we follow this patient, this lesion, before treatment and after 2 months, and this is a time intensity curve. We are moving to the GIST. This is a patient with metastatic in the liver, so before treatment, 2 weeks, 1 month, and 3 months, and the quantification. Another very interesting patient. This is a comparison between the Troy criteria, the famous Troy criteria from the MD Anderson and at Houston. If you follow this lesion, the useful units is 47 at the beginning. And after 2 months, this is 32. So this is as a good response according to the Troy criteria. But when you come back after 4 months, we increase to 45. And after, we decrease to 34. So finally, it's difficult using the Troy criteria to evaluate this patient. But if you use a contrast agent, this is at baseline, after 2 weeks, after 2 months, and 6 months, you are able to evaluate very high efficiency these treatments. We are moving to the breast cancer also. This is a patient, a woman with metastatic in the liver, before treatments in B mode. using contrast agent, and it was this lesion on CT scan, and this patient had avastin during 14 months, so this is more than the progression-free survival that they published in their huge publication. And we followed the patient after 1 week, you can see the beginning, and after 2 months a necrotic area, and this is a CT scan and the quantification curve. So the last example is an amazing story because it was a phase 1, and this is a new combination. This is a new drug, so currently this is a confidential drug combining with radiotherapy. Remember, currently we have new approval drug in melanoma. It was a patient with a huge lymph node in the axillary area, and it was a lesion, and this drug, when we start, was not anti-angiogenic drugs, but we decided to use these techniques in all phase 1. We checked the patient only after 1 week. So without contrast agent, it was impossible to understand the answer at the beginning of this evaluation. But when we inject the contrast agent, we have a dramatic decrease. It was amazing, amazing answer. We never had this kind of answer in melanoma. And finally, the company decided to push now a lot of patients with melanoma. We don't understand the mechanism of this drug, but we understand probably for the melanoma it will be very nice. And we confirm the answer of this patient. You could check the CT scan. This has a show answer, you could say a necrotic area, and when we inject, we have only a small contrast uptake surrounding the tumor. So now concerning the national study, we try to evaluate the quality because it's also very important in United States. So you are starting this new methodology now, and how we evaluate the quality of the acquisition. So we decide to give a score between 0 to 5, and finally we only delete the number 0, so this is only 3% of the acquisition. Concerning the score of the radiologist, and you had to remember, if we perform less than 10 examinations, this is only for training. But finally, if you perform more than 50 examinations, it's not so much. This is only during 2 months. You are able to have a very high quality for the acquisition. So finally, it's very easy to learn and to teach this new technology. Concerning the very important parameters, remember the number of examinations. It's better to have more than 50 exams. And also, and I so that you understand in different examples that I saw you, if you choose a metastasis without motion, the quality is better. So if the patient has metastasis in the liver and metastasis in peritoneal area on the neck, it's better to choose immediately the lesion without motion. Concerning the cost, it's very important in the United States, but also in Europe. The time for the radiologist is only 23 minutes. And we understand that in 20% of the cases, we inject twice vial at baseline. It's very important to have a very nice acquisition at baseline. And the cost, including the staff, the contrast agent, the equipment, the quantification, is $273, so it's not so much for the functional imaging, and it's 182 euro. So now our goal is to build an European and international network. So we try to start, we start a collaboration with the Harvard team in Boston with Annick van den Abele and Donald DiSalvo. So now they are the same machine, the same methodology. We also diffuse the techniques in Royal Marsden in London and also in Institut di Tumori in Milano. I am a new chairman of the European Organization of Oncology in order to push this technology in functional study. And we are starting in renal cell carcinoma with Pfizer. And we also start with a phase 1 study with companies, for example, with Sanofi Aventis. but also we teach the Korean center in Seoul, in Hasan Medical Center, the Samsung Center, and University of Seoul. So currently we create this network, and we hope that we reinforce this network with the United States, because now they are starting the study with Sonoview. So the last point, teaching in the world and to provide guidelines. So teaching in the world, in the European Congress, we try to perform the workshop combining MRI, DCE-MRI with Padani, CT perfusion, and DCE-US. I am a chair in the European Society of Oncology, and we try to push our imaging session in oncology. We organize international course for training, and we also teach in China, Korea, Thailand, and Australia. Concerning the guidelines, it's a very important point. This year, the European and world guidelines will be provided in August in Vienna, and this methodology will be included in the guidelines with a level A of validation. So to conclude, remember, this new technology is a dynamic contrast enhanced ultrasonography using the raw linear data and the bolus injection allow us to calculate different functional parameters. Remember the determination of threshold of quality. If you perform more than 50 examinations, this is excellent quality. And finally, probably the eye under the curve and the washout are predictive for tumor response and overall survival, and these parameters could be a potential surrogate markers of the efficacy of anti-angiogenic agents. And in fact, the next step, the future and the challenge will be the 4D acquisition in raw data in order to avoid the operator dependence of the ultrasound, and we hope that all companies develop a very new probe able to perform this 3D acquisition during 3 minutes. I hope you enjoyed this talk, and I hope to meet you in order to create the network. Thank you.